Hello everyone, welcome to my channel 20th Notebook. What's in store for today? Today in this video I'll be talking about leave me alone lesions in musculoskeletal system. So this is our template. You can see we used to have a cheat code for everything in GTA, and there was a cheat code whenever we needed to escape from people. We used to type leave me alone. So this is just a template to help you remember these leave me alone lesions. I'll these topics have been chosen because soon I'll be uploading a video on bone tumors. So these are common confusers with any bone lesions. So let's go through these lesions first. These are not that important but less spoken about during your coaching classes. So I'll just take you 15 minutes of your time and help you quickly learn all these leave me alone lesions in musculoskeletal systems. So what exactly are these leave me alone lesions? Leave me alone lesions are all those lesions which are very classical, have very classical imaging findings as indicated by the name, and do not require any further investigations. These can be misleading with other lesions and hence lead to unnecessary surgery. So we should always diagnose these lesions without any list of possible differential diagnosis. So moving on to our first leave me alone lesion for the day, which is bony islands, or also known as anastosis. What are they? They basically present a focus of cortical bone which is located in medulla. It can be, so basically cortical bone which is located in medulla. These can be developmental or congenital. So where are they most commonly seen? In the medulla of pelvis, femur and other long bones. Okay. What are the important points to remember about these bony islands are multiple bony islands are seen in osteopoikilosis and osteopathia striatica. So both of these are autosomal dominant conditions where the bony islands are located in periarticular distribution. These may be round in osteopoikilosis or elongated in osteopathica striata, as indicated by the name, striated appearance. Okay. So imaging wise, how do you see this? So you can see that a dense sclerotic focus with a characteristic spiculated margin, okay, is located within the normal medullary cavity of a bone, of the host bone. So on MR also it shows very low signal intensity on all pulse sequences. This you need not remember that. However, remember the thorny edges and brush-like border are present in the medullary cavity of a bone. This is a normal benign finding and you need not do anything else. So what is important thing is they can be confused with sclerotic mets or with osteoblastic mets. So how do you differentiate is sclerotic mets is on MRI you will see that sclerotic mets are round and are surrounded by T2 high signal sequences, and also they have contrast enhancement. Okay. However, osteoblastic mets, you need to remember that bony islands do not show uptake on skeletal scintigraphy. This is not true with osteoblastic mets. They have uptake on skeletal scintigraphy. Okay, that's all. Moving to classic imaging appearance of osteopoikilosis, as you can see here, multiple bony islands mainly located in the periarticular margins, typically round in location. These are the classic imaging findings of osteopoikilosis. These are round as the name suggests. As the name suggests in osteopathia striatica 2, these are long and linear. As you can see here, nice pencil kind of appearance within the bone. The same goes here with the X-ray of pelvis. Okay, these are some of the touch me out lesions of bony anastosis. Next, I'll go ahead with fibroxanthoma. It encompasses two identities, that is NOF and fibrous cortical defect. So how some important things you need to remember. These both are benign hematomatous lesions of children. So how do you differentiate both of them is FCD is usually small. Since it's small, it is usually located or situated only in the cortex, and it appears at a very younger age, that is around 4 to 7 years. It is silent, does not have any clinical features, and hence it does not need any treatment. NOF, however, on the other side, is appears in older children. It can expand to medulla owing to its larger size of 7 centimeter up to 7 centimeter, and it usually presents with pain or fracture, and hence we treat it with curettage. So most of the lumealone lesions does not need treatment, but you need to remember that NOF is a type of lumealone lesion which has treatment and has characteristic imaging finding, and hence does not need any biopsy or any other things of sorts. So speaking about NOFs, where is it located? It is centered on bony cortex. Okay. So majority of them involve the lower limbs, especially tibia and distal end of femur. Clinically painless, as I have told, unless it is large enough to cause pain or fracture. So multiple NOF is associated with some syndromes like NF, neurofibromatosis, and Jaffe-Campanacci. This is not that important. So there are some cryptorchidism, hypogonadism, and Café-au-lait spots associated with this syndrome. So radiologically, what do you want to see? Basically, it is basically well defined, eccentric, that is cortical based and expansile. But the most important thing is its location within the metaphysis with associated sclerosing margins. Okay, so I'll show you an image now. According to the table, you need to tell me what are these two imaging findings referring to here. So as you can see, I had initially told you a lesion predominantly located in the cortex, having a dense sclerotic rim of size between 1 to 3 centimeter. So what does this speak of? This is a classical fibrous cortical defect. Okay, this happens, let me tell you, as you can see, there is a unfused end plates, so epiphysis is not fused with metaphysis. So this is a child, so you can guess the age might be less than 6 years. So this is a case of fibrous cortical defect. However, this is also similar. You can see sclerosed margins, but however this is bigger. It's around, say, 5 to 7 centimeter. And one more important thing to notice, it is slightly encroaching on the medulla. So what is this? This is your classical NOF, bubbly kind of appearance. So this is attributed to soap bubble appearance, usually enlarging into the medullary cavity. So this lesion is along the long axis of the line of bone. Okay, there is no periosteal reaction to differentiate it from tumor. As you can see, there is no periosteal reaction as such. However, if there is associated fracture, then there will be periosteal reaction. Okay, only exception is that. Next, we will move on to the next lumealone lesion, which is your simple or unicameral bone cyst. So basically, what is it? It is a lesion of unknown etiology, and it is not considered neoplastic. Okay, not considered neoplastic. So this was cross. Okay, not considered neoplastic. These are usually solitary, like always solitary, but they need not always be unilocular. They might be multiloculated as well. So what is the age you associate them with? 5 to 15 years. And so there is a predominance of males, especially seen in, most commonly seen in your humerus. Okay, proximal end basically. Sometimes it is also seen in femur, and other sites are also calcaneum and SI joints and other stuff. Calcaneum, SI joint. So imaging wise, what do you look for when you think of unicameral bone cyst? So same thing, It will also have a sclerotic margin. It will be a solitary cystic lesion, and one important thing is it can cause scalloping of the cortex. So like this scooped out appearance of the cortex. There is again no periosteal reaction unless there is fracture, and the overlying cortex is never completely disrupted. The important radiological sign you need to remember is the fallen fragment sign, which happens due to secondary to pathological fracture, where the fallen fragment of the bone appears on the dependent portion. So I'll show you images so that you can associate them with the findings I have described below. So imaging wise, you can see there is a unilocular bone cyst. I have given a less classical location of femur. So it can be located in femur, but most commonly it is seen in humerus. I have taken 2 images of femur just so that you don't rule it out when you see such lesions. However, you can see this is a unilocular, but on the right side you can see that this simple bone cyst is multiloculated. The overlying cortex, as you can see in both the cases, is intact, and you can also see there is some sclerotic rim, but however there is no periosteal reaction. So how do you differentiate it from true neoplasm is these findings. Okay, moving on to the less commonly talked about thing, which is bone infarction, which you need to know, because there is in this case there is ischemic death of the cells of bone and marrow both. So we can also name it as we also know it by better name, that is osteonecrosis. It can be idiopathic, or it can be due to conditions which lead to secondary decrease in blood flow. You can associate it with multiple things, but the imaging wise you need to remember some 2-3 important things. Where is it located? It's located in metaphysis, within the medullary cavity. It can be symmetric both sides, and it can be multiple. But characteristic thing is the serpiginous borders, snake-like appearance. Okay. So sometimes what happens is they will appear late between the onset of clinical symptoms or histopathologically to the radiological imaging findings. But remember, you can't rule it out. So because there might be a delay in appearance. I'll show you the images. These are the classical images. As you can see, the serpiginous margins like this within the medullary cavity. Within the medullary cavity can be bilaterally symmetrical and can be multiple. So on MR, how do we say is it, unlike bone tumors, marrow tumors, where there is difference in medullary signal and lesion signal. Okay, medullary and lesion signal, there is discordancy. However, you can see that medulla and the lesion both have same signals. Okay, only thing is it is having a peripheral rim of low this is a peripheral rim of low signal due to granulation tissue. You need not remember that, but just remember that classical appearance of bone infarct, which will be like this. Then this is one more one more important thing you need to remember in bone scans is how do you on bone scan in bone infarct, what is the appearance? So there is cold spot because there is no bony uptake, as there is no blood supply. So, peripherally there might be some increased supply during acute phase. Okay, that thing you need to remember. Just moving on to the next important thing, which is myositis ossificans, where there is extraosseous localized non-neoplastic bone. It's non-neoplastic, that is important thing. So bone and cartilage is formed. Why is it formed? Basically because of heterotopic ossification. It occurs mainly in skeletal muscles. However, remember this is a misnomer as there is no inflammation. What other thing you need to remember is the causes, which is direct trauma, most of the cases, 75% cases. Then we have paralysis, burn, some hematoma, tetanus and other stuff. Spontaneous also. It is most commonly seen in adolescents and for some reason young adults, and for some reason there is male predisposition. The important thing is there is a mimic where there is that is if there is no trauma, what do you call it? It is called as pseudo-malignant osseous tumor of soft tissues. So what is happening here is basically in myositis ossificans there is interstitial hemorrhage, then there is subsequent mineralization. Mineralization is first usually seen in the periphery, then there is a gradual reduction in the size of mass. Okay, so important thing you need to remember is do not biopsy because this immature appearing lesion may mimic osteosarcoma and the patient as well as the doctor might panic. So basically there is classic imaging appearance of myositis ossificans with some history. You can always rule out osteosarcoma and you need to just go ahead and leave it alone. That is why it is a leave me alone lesion. Imaging wise, what do you want to say is basically you will see heterotopic calcific ossification within the skeletal muscles as seen in CT and X-ray. There might be associated fracture somewhere where a person has tried to fix it and has caused heterotopic ossification. All your osteopaths. Okay. Other than that, we'll go to the next miscellaneous lesion. These are lesions I am covering just for completion sake. These definitely won't appear in NEET, INI, FNG or any exam for UG entrance examination, any exam of sorts. So I'll just I'll just talk about them in 15 seconds each. This is a pseudocyst of humerus where you can see a well-defined lytic kind of radiolucent zone in the usually seen in the greater trochanter. Why is it important is it might be confused with GCT, METS or chondroblastoma. Okay. Other than that, so it does not require biopsy or any additional findings. It is a benign condition. Other than that, I'll go to the next one, which is dorsal defect of patella, as you can see here. So this is also a benign subchondral lesion. It is basically developmental alteration of epiphysis due to delayed or failed ossification. So you need not remember much, but it can be mistaken for pathological process like so focus of infection or osteochondritis dissecans. So just a mimic. So this condition is very common in patella and it need not have any other further investigation to be done. Then there is one more important thing, which is avulsion injury as seen here. Avulsion injury is common in multiple sites including head of humerus or any sites where there is attachment of tendons. So clear history will be there. So history is the main clincher. As a portion of cortical bone here will get ripped from the rest of the bone by the attached tendon. Okay. It is common in people who participate in sports. So just remember that because of eccentric muscular contraction, such injuries might present with severe pain and loss of function. However, these are benign and you do not need to get any further investigations done for the same. So other than that, there is one more important entity called cortical desmoid. So what happens in this condition is it has a very typical location, posterior medial condyle of femur. Okay, this is because of repetitive pull at the site of attachment of medial head of gastrocnemius, repetitive microtrauma and adductor magnus. So it is bilateral in 50% of the cases, and hence can be ruled, or any malignancy can be ruled out. Biopsy should not be performed in such cases. It might have in young patients there, because of the appearance of irregular bone, it might mimic osteosarc again histopathologically. Do not biopsy it. So just remember that, and you can perform, if you have any doubt, you can perform another imaging after 3 weeks. It will subside. Another important entity, last two important entities which come under this touch-me-not lesions are pseudo dislocation of shoulder. As you can see, that the shoulder does not appear to be in place; it appears dislocated. So you might think that there is a occult. So this happens because of a occult fracture. You might think that there is dislocation, and you try to put it back into place, but the shoulder humerus height never relocates. Okay, and it might cause further pain. Here you can see that there is high density fluid which is having dependent location. So this is because etiologically it is due to hemarthrosis of shoulder joint, which might be due to occult fracture with distension of glenohumeral joint by the hemarthrosis. Okay, do not mistake it for any inferiorly subluxated shoulder joint. Okay, and do not try to fix it. Then there is one more small entity. I given a CT image for the same, which is known as Pitts-Pitt or synovial herniation pit. It is seen in the anterior superior aspect of neck of femur as shown, just distal to articular surface. Here there is herniation of synovium or soft tissues into the bone through a cortical defect. There will be small defect through which there is herniation into the bone. Okay, no, you need not do anything for such lesions. There are many other touch-me-not lesions, leave-me-alone lesions. You can also call them as touch-me-not or leave-me-alone lesions. But these are some of the important ones. I'll just have next quick session on bone tumor in a few days, in upcoming days. So this was just an introduction class for the skeletal pathologies, which are not covered in our 28 notebook as well. These lesions needed some explanation, and hence I have uploaded this in a separate video instead of just giving it as theoretical aspect in notes. Stay tuned for the next video on bone tumors. This will the video on bone tumors will be interesting, and you will enjoy it, and it will be like 20 to 30 minutes session only. Thank you for listening. All the best. Please like and subscribe our channel, and do not forget to press the bell icon.